get started, thank you for being such a wonderful, intimate group this morning. You're going to get a lot of good discussion. I can feel it. We're going to have so many ideas flowing. Thank you for being here at 8 o'clock on Friday. My name is Jessica Vaught, and this is Upstander Interventions across the educational continuum, and these are my co-presenters.
I'm Jeff Hayes from ADIEM University.
And Mark Berenson from Stanford.
So we have no disclosures, and here are our objectives. We want to demonstrate the importance of faculty and resident development in recognizing mistreatment and implementing Upstander interventions. We want to evaluate various pedagogical modalities available to teach residents and faculty how to implement Upstander interventions and develop strategies to create adaptive, sustainable curricula that respond to the needs of the institution and our learners. So this talk came out of a local need. So I'm a clerkship director, so I shepherd 100 students annually through our mandatory clerkship in emergency medicine. And so I am the recipient of the students' harassment and mistreatment reports, which they are asked to file should they experience harassment or mistreatment during the rotation. And I'm very pleased to say that by and large, our students do not experience harassment and mistreatment. And when they do, it's not egregious behaviors by our faculty or by our residents, but more typically, it's a microaggression by a patient or by staff. And the students have this concern or this desire for faculty and residents, for those who are ahead of them in the medical hierarchy, to acknowledge and support them when something like this happens. We can imagine a student is in the room, a patient refers to them as sweetie, it's a microaggression, and everyone walks out of the room and it goes unacknowledged. And the students are asking for recognition of leadership roles of faculty and residents, even when they're not the perpetrators. They didn't call them sweetie, they didn't do anything wrong, but they still want to be acknowledged. And they still want someone who's ahead of them in the hierarchy to check in with them and say, hey, how are you doing? This happens, how do we handle it?
Good morning. I will admit there's 3 more people here than I thought there would be. Mistreatment can be difficult to address initially because it can be difficult to recognize. Mistreatment also has several different definitions. For the purposes of this talk, this is the one we've chosen. Any behavior, intentional or unintentional, that shows disrespect for the dignity of others and unreasonably interferes with the learning process. This can be tricky because mistreatment can be intentional or unintentional. That means it can be noticed or unnoticed. It can range from something quite obvious, as what happened when I was a medical student, where I had a resident colleague who was in the operating room, and from her bouffant camp, her bang fell below. Surgeon asked that to be fixed, so this rep tech came over with a pair of scissors and sliced it right off. It's a very clear and blatant episode of mistreatment on a medical tree. It can also be more subtle. It can be unintended by the people who are doing it. It can be as simple as a comment, as Jess was describing, which can really impact how people are feeling and their ability to learn. So as faculty in this environment, how are we to respond to something that we don't even recognize or aren't even cognizant of in the moment? Mistreatment is well reported in resident populations. Up to 60% of residents have reported mistreatment in some form or another. Verbal mistreatment is the most common form that's been reported, including episodes of public humiliation and public embarrassment. Sources come from consultants, that's us, faculty, patients and families, and fellows and residents as well. As we go through the data presented here, we're going to see, as Jess was alluding to, a key population of people who are the perpetrators of mistreatment are not included in this data set, and that is patients. And that's a very tricky and complex relationship to manage, because if a patient says, oh, hi, sweetie, how are you? They might not mean offense, but they might be, in that moment, very offensive and kind of altering that relationship. Mistreatment is also been reported amongst the medical student population. This data is from the 2024 AAMC survey, graduate questionnaire, at which point 36% of medical students who are graduating did report experiencing mistreatment at the hands of faculty, nurses, residents, other students, or institutional staff. the questionnaire specifically excluded patients as a source of mistreatment, and so that alters the way that we're going to kind of go through the data, because it would also alter the way in which we would approach a training session about how to empower faculty or senior residents to handle this. The emergency medicine rotation was cited in 6.1% of mistreatment reports, but in 2024 was the first year that emergency medicine was included as an option for students to document where the mistreatment was coming from. So we only have one data point here, and I'm curious to see how things go over the coming years. But 2023, 2022 not included, so no data or information there. Impact of mistreatment on the learning environment. I think it's worth saying, but I don't think any surprises are contained here on this slide. If you are a learner who has experienced mistreatment, you are unable to fully learn or process or participate or engage in your education in that immediate aftermath, and depending on the nature of the mistreatment, perhaps for several moments or hours afterwards. Isolation. Is it just me? Have other people experienced this? What did I do to incur this episode? Role ambiguity. What do I do now? If you are a medical student, for example, and you're in a rotation like the emergency department where you have been put in the decider role to be the physician for the first time perhaps in your medical career, and then you experience some sort of mistreatment from a support staff or from a colleague or from a teacher, you might then be confused about, am I supposed to still be vulnerable to make these decisions? Am I still supposed to be doing this? Do I come back? Does someone else have to take over this encounter for me? Struggles with empathy. I think, traumatized people traumatize people. You are traumatized in the moment, and no one who works in the emergency department is not traumatized on a daily basis. Your ability to appropriately encounter and care for patients goes down. This leads to things like burnout, which is outside the scope of this talk, but certainly one important element that deserves to be considered. Barriers to addressing mistreatment. The interventions and the strategies for bringing this sort of training to your institution will help to cover some of these. But really, recognition is the big one, right? You cannot intervene if you don't recognize them. Not knowing what to say, not wanting to jeopardize your relationship with the patients, your relationship with your colleagues, all of these are very specific. And depending on the moment and what your relationship is to the person who's been mistreated versus what your relationship is to the person who's done the mistreatment will impact your ability and your approach when you are taking this in. So for example, I'm a junior faculty, and this is just by way of example, this has not happened, but let's say a department chair comes in and, oh my God, you're such too pretty to be a doctor. How do I intervene on the department chair's control over me? As an example, my mom is a physician. She trained at a time, she was one of 5 medical students in her medical school, and Jimmy Carter came to visit while she was a medical student and just came up and told her, you're much too pretty to be a doctor. And she's sitting there with the President of the United States who told her that she's too pretty to be a doctor. Like, that's an episode of mistreatment. No interventions occurred on President Carter at that time, and I don't think anything was intended by that other than a compliment about her physical beauty, but that was an obvious episode of mistreatment by someone in a position of power. Not wanting to jeopardize relationship with colleagues, also very important, as we just discussed through here. All right.
And so begins the interactive portion of our talk this morning. So how many of you guys have been part of Upstander training at some point in your career? Looking around at people in the room, how many of you have been part of creating Upstander training? Okay, good. So we actually have some stuff to talk about. Upstander training can be incredibly useful in starting to move the needle on making a culture where intervening is okay. And when you think about that, that means that Upstander training needs to happen at all levels, from the medical students to the residents to faculty and staff. And if you're really going to push this the right way, it also needs to happen within your healthcare systems at all levels of staff within the healthcare system. There needs to be that big group buy-in. In order to make that realistic, it has to be good. And there are a couple things that you can do to help make it good. The first of which is to choose a framework. Figure out what setting you're going to deliver it. Make sure you've done an institutional needs inventory, setting ground rules, which I'm going to spend a little bit of time talking about, and then practicing. These are going to be our core components we'll talk about in the next couple minutes. So there are so many different frameworks that can help us understand how best to intervene. The one that I was raised on is actually not on this list, which is the challenge framework. The ERACE framework is one that's commonly cited and used within Upstander training. I will tell you, I don't think it matters which one you choose. It matters that you choose one and create common language and expectations of your learners in all settings. So when these moments of mistreatment occur, whether intentional or unintentional, everybody understands what's happening when you start that upstanding moment. The erase framework up here, very briefly, just to discuss. So expect that such events will happen and prepare accordingly. We don't want them to happen again. We know that they don't always happen intentionally, but we need to know that it's a fact of life. We need to be able to recognize it. Next, we address that situation in real time. And some of these other ones give you some language to use around it. And it's okay to integrate more than one framework into your Upstander training because they may have different uses at different point of that training. Support for the learner after event. And by doing all of these things, we contribute to really establishing and encouraging that positive culture we're trying to encourage. So the next thing is the setting. So the first thing you have to think about when you think about the setting is what resources do you have? How much faculty? Who are going to be the faculty? How much time is there funding? And that's going to drive a lot of your educational modes. When we at Rutgers started creating Upstander training, it was actually started in a process that brought medical students in across 4 years of experience and shared their stories of mistreatment. And from that, we built vignettes. And those vignettes actually were taught by senior medical students to junior medical students, partially because we couldn't get the faculty time in order to run the training. So it can require being a little bit creative in order to get the message out there. Obviously, large-scale institutional buy-in would be the gold standard. We know that, especially in light of current events, that may be less likely to happen. So we need to be smart about how we can keep that work moving forward. Large group lecture is going to be wonderful for disseminating one message and horrible for getting people to share experience and create connection. So you would get that in the small groups, a lot more variability in what's going to be discussed, even with standardized curriculums. Embedded SIM is great and is resource and time intensive. In order for SIM to reach many people, you have to do it a lot, right? And again, if you've got the time to protect, that's great. Standardized patients are wonderful for these experiences. Again, quite expensive, so it's a little bit of a rate limiting step there, but can you integrate it into one of your courses on doctoring, for example? Can you find ways to use existing SPs and add an objective to that encounter that helps get that Upstander training in? And then obviously working with our colleagues in nursing, other allied health professionals as well, because they have buy-in for this, and maybe even more buy-in for this, right? There's a world where the nurses actually feel much more mistreatment than we do as the physicians because we do hold some power and privilege in that role, and they may have some expertise and some resources to share in combating the problem. So going back again to this institutional needs piece, we should never be pursuing an intervention without starting with empathy, and starting well with empathy means getting good data. So thinking about what's actually happening on the ground, where are our problem points, and where are the things that people feel we need. Maybe everybody's fine acknowledging, recognizing that there's a problem, but have no idea what to say in the moment. So your intervention is going to be highly focused on, here are specific words you can use in this moment. Maybe you don't actually know, you don't have people who feel comfortable recognizing when smaller mistreatments occur, right? And it shouldn't be assumed that everybody has the same level of knowledge about these things going forward. So taking that time to get that data, figuring out where is my pain point, and then you can start addressing your intervention to be specific. In all of these trainings, people are likely going to end up sharing things that are deeply personal, that may involve times when they've experienced mistreatment at some point in their lives in their training in the workplace. In order to make sure that that happens in a psychologically safe way, it's important to establish some ground rules. This is one list of ground rules. There are multiple lists of ground rules. There are acronyms for ground rules. Again, it doesn't matter which one you pick, as long as people know that the conversations are confidential, that people may make mistakes when they're responding to comments, and that's okay, that it's okay to say, oops, and say, let's start over, I'm so sorry. It's okay to have differing opinions. It's important to let people speak without interruption, and that we will leave this room judgment-free. So one of the things that I really like is the universal statement that's used by the SAEM group out of Harvard, right? And what does that all say? We come to this space trying to do our best, caring about patients. We make that underlying assumption about each other, and when we do that, we facilitate better communication and a better educational experience. And then last but not least, just like a speech that you're doing at SAEM, if you don't practice it, it's not going to be good, right? So you have to get those reps in. You have to make sure your team is facile with the information. They're updated as we continue to expand the body of literature around Upstander interventions, and that they feel comfortable enough and vulnerable enough to share themselves, right? Because we all need to bring ourselves onto the same level for this to be successful. And you need to be intentional about how you do the development for your faculty. Whether that faculty is senior medical students, residents, attending physicians, nurses, social work, psychologists, whoever it may be, they all need intentional preparation beforehand.
So I think Mark did a great job of just kind of describing the issues of scale and how to put different people through different trainings and what pedagogy you might have at your disposal to bring your Upstander training to the target audience. But I did want to briefly kind of highlight where my mind goes right now, which is toward AI, and how can we use AI maybe to generate conversation, maybe to respond to prompts, maybe to just keep track of some of the themes that come out of a broader discussion. And I think that could be a very interesting place to bring this kind of training. So let's do some examples, and I'm going to call on my colleagues to kind of help me workshop this. So I have a problem because I got a harassment and mistreatment report. Dr. Bod, you need to do something about this when the patients are screaming racial slurs because they're intoxicated or psychotic or otherwise disinhibited. They're doing this in front of the students and nobody said a word. So now I have 40 residents. I want to teach them how to do an Upstander intervention when patients are using racial slurs, and I want to teach them how to intervene in real time and set verbal limits. How would you bring this to your target audience?
This one's interesting. I think so. If the scenario is that the patient is intoxicated in some way, there is no verbal intervention that will happen on the patient that is going to be super successful. I still think training the residents would be a good idea. I would start with a kind of a large lecture format, describing whatever framework we have decided as an institution to use. Ideally, I would run them through SIMs after that. You know, communication is such a big thing that we need to train, and standardized patients can be super helpful with things like delivering bad news, or team management, or instituting an Upstander intervention. That I think costs can be mitigated by trying to concentrate that in one day of conference. So if you do your conference all on one day, that's what my institution does. We can run through several scenarios with standardized patients to kind of go through that. So I would kind of start with that like lecture, and then we'll run through a sim. I would probably do it in such a way where you've got one person as like the team leader who then experiences the mistreatment and then goes through kind of their intervention, maybe 2 or 3 others in the room, and then maybe 3 or 4 in a debriefing room, and then debrief together as a large group. So that way you don't have to run 40 residents through like one sim over and over again, but maybe you can get 10 residents educated through one individual experience.
God, I'd love to get 5 hours of conference time for this. It wouldn't happen for me, right? Our schedule is so jam-packed. If I get an hour, I would be lucky. So one of the models that I would consider using here is video-based education and filming some scenarios and demonstrating some techniques for them so they can actually see it live time with some of these concepts we're talking about today interleaved. And it's just a way when you're compressed, but you still want to deliver high-quality education and give people a model with which to intervene, could be highly successful.
Okay, so now you have another example. So now you have 4 new faculty, they're onboarding, and you want to teach them how to handle a scenario where perhaps the staff perpetrates a microaggression. And these are people that your new faculty are going to have to work with and be collegial with. And so you want to teach them the intervention of gentle redirection. How would you bring that to your target audience?
Small group.
Small group.
I'll elaborate. If you're onboarding a set of new faculty into your institution, that group of people does not have an understanding at of what the norms or culture of your institution is and what's acceptable and what's not acceptable. I think every institution has some sort of statement or policy against mistreatment. They should. But the levels to which those are enforced or interpreted in each institution vary. So this is your time to sit down with them and really make clear what the expectation is, not only for them, but for other people in their department. I would then, kind of run through the scenario and probably do a little, I think it's really helpful to do a tabletop. Mm-hmm. So maybe write a couple scenarios on paper, let's read through them as a small, 4 is a really good number to get some ideas out and people talk through, and then we can practice some scripting there. So I think once the standard is established and confirmed by, in that moment you are the senior physician in the room orienting other faculty, then running through that scripting will help give them a place to go. It's another great moment to make sure they're aware of any sort of institutional reporting mechanisms that exist and how to access those in your institution.
I agree with Jeff. The only thing I might add to that is I might bring in some of the other stakeholders that they'll be interacting with in the department for that conversation, and really try to make it collegial and have maybe folks share some stories, some experiences, and also start to create some connections for these new faculty as well. Because I find that the more we're connected to people in authentic ways, the less total number of episodes of mistreatment we see.
So I don't know how we're doing that time, actually.
It's 8:21.
Oh, okay. So if you have any harassment or mistreatment incidents that you'd like to workshop with us, you can feel free to contact us. We can try to figure out how to implement something for you. But in summary, mistreatment of trainees is common. It impacts the learning environment, and Upstander interventions can be taught to mitigate that impact. You should consider your specific institutional needs when implementing an Upstander curriculum, and consider your specific pedagogical options to bring your curriculum to the target audience. Thank you.
Has anybody in the audience kind of experienced or witnessed mistreatment at the hands of anyone else for a learner? Yeah, I think that it's I don't know, it's incredibly demoralizing even to the person who's witnessing. So by way of example, we were taking care of a patient who, a trans woman who came in for abdominal pain. The reason she had abdominal pain was because she had a large spleen laceration from the assault that she did not disclose for fear of disclosure. And she just kind of kept wrapping her scarf around her abdomen, saying it was tender. So CT came back, blood in the abdomen. We're going emergently to the operating room with trauma. The OR charge nurse refused to allow her into the OR without a pregnancy test. Then when explained that this was a trans woman who had a penis and testicles and the pregnancy test was not indicated, she demanded that the resident go look between the patient's legs to see what was there before she would allow the patient into the operating room. So that episode, that was mistreatment on the patient, affecting the resident and the nursing staff. These are things that, some require different levels of intervention. And so I think it's important to remember, even if the learner is not the direct recipient of the mistreatment, being witness to mistreatment of people can be incredibly demoralizing and dehumanizing. And I think it's our role as faculty to set that standard and then take the appropriate intervention in that moment was sound the alarm, and this will not stand in a very direct way. There's different mechanisms everywhere, but I think it's important for people in this room to feel empowered to do that.
I think for me, after 35 years, I would say that individual conversations in a quiet place for nurse in particular, it doesn't help to write anything out. Just trust me on that. Well, yeah, after decades, it's the communication and the trust you build with your team. And national team staff says learn to cuss, right? I don't know, I came in late, so I don't know if you talked about that. I'm concerned. Help me understand. I feel that situation didn't go as well as I had hoped it would. And I feel like the patient's feelings could have hurt, and I don't think we've been good. I know we both want to have best practice medicine applied, and I don't think ordering an unnecessary test is, how could that have gone better for you? How could I have conveyed information better to you that would have made us a better team? I just think that one-to-one, a moment where there's not a lot of people around, we're not trying to do anything, and then that's what we teach our learners, right? But in a different environment.
Yeah.
One of the struggles I've had though with the one-on-one conversation is there's also an element of the employee has a right to confidentiality, right? And that how you communicate to a public group that may have witnessed, rounds, and EM is a very public sport. And so when people feel, whether it be a microaggression or outright aggression, feel wronged and then want an answer to what have you done about this, and really the only thing you can say is it has been addressed. So I'm interested, do you have any, any recommendations of how to reassure people that it has been addressed in a meaningful way?
That's such a tough thing, right?
Agreed. That's why I had a program director.
No, I love it. So I would say that there are two things. If you already have a program and a culture talking about Upstander Intervention, that work becomes much less, right? You, instead of putting out the fire, you were thinking prospectively, and people were going to say, well, luckily we were able to intervene as we train everyone to. No details shared there other than saying this, we followed our usual process. And if that's not built up there, this is where you have to maybe be humble enough to say, we can't talk about what happened in the circumstance, but boy, maybe we should partner together to think about how we can make this happen less and how we can build a system.
So then do I
that's the
do
opening conversation to initiate.
presentation?
I know that's a highly unsatisfying answer, and I don't know that I have a better one.
I agree. So I'm a program director in my institution, and I think
Okay, perfect.
if you
Great,
get to
thank
that
you.
point, and we're going to start using this next round and prepare as well. But if that moment has already happened and the pre-work has not been done, you're too late. And so that moment, I think, is not going to be salvageable because sometimes people just want public, flailing of whoever the person was. So I think setting the tone initially, and I try really hard with my reference to be clear with them. I will not lie to you. I respect you enough to tell you the truth all the time, and there are moments when I'm going to have to tell you that's the rest of your community to trust me, and building that trust should have happened in the most preceding. So it's a long-term game. I've personally encountered this problem 2 times. It has changed the way I do orientation in anticipation that in 6 months or 12 months I'm going to have a problem. I'm going to need to just say I've dealt with this, and people are going to have satisfied with that. It's hard to do.
Thank you guys so much for coming at 8 a.m. We really appreciate it.
Strong show for you.